This presentation is over pulmonary embolism. It is in partial fulfillment of NSG 576. Some housekeeping rules I'd like to establish. If students have any questions, I would be more than happy to answer them, but I ask that you please refrain from asking during the middle of a slide. Just wait until the end of the slide and then quietly raise your hand, and then I can call on you. A pulmonary embolism is a blockage of one or more pulmonary arteries from a thrombus, fat or air embolus, or a tumor tissue. Now, emboli specifically are mobile clots that lodge at a narrow part of the circulatory system. We may find that they come from most commonly from the lower extremities. They gain access to the pulmonary circulation from the venous system, and they obstruct perfusion of the alveoli, the sacs that we find within the lungs needed for perfusion. The lower lobes of the lungs are most often affected. Now, an important thing I would like nursing students to understand is that pulmonary emboli are potentially life-threatening complication. They vary in estimates, but about 600 to 8,000 cases of pulmonary embolisms occur, and about 60% of those patients will die within the first hour of a massive PE. It is also one of the third most common causes of deaths for elderly patients and is often a commonly misdiagnosis. So, with pulmonary embolisms, there are also quite a few risk factors involved. To begin, we have a history of DVT. So patients with a history of DVT are more at risk for having further emboli. In addition, if they currently have a deep vein thrombosis, it can begin to further grow and also fall off and find its way into the venous system. Atrial fibrillation is a really big one. Typically with AFib, you see that there is irregular heartbeats. The heart is not fully contracting. So because it's not fully contracting, there's blood that kind of stays in the atria. Because it's staying in the atria, it has more of a chance to clot, and that clot is able to be sent over to the pulmonary arteries, and then it can also be sent actually to the brain as well, causing strokes. Surgery, which I'll kind of tie into pregnancy, immobility or reduced mobility, they are pretty much related in the sense that after surgery uh, and pregnancy, you just don't have as much mobility, especially if there's a C-section. But this mostly includes any type of surgery. However, the more invasive ones are definitely going to cause more reduced mobility, especially in ortho patients as well. This is typically why if you ever work on an ortho floor, it's really dependent on the orthopedic doctor, but they will typically want their patients walking as soon as they can. Some orthopedic docs will actually won't even take patients unless they know for sure they are able to um, engage into whatever treatment plan or follow-up care that they can agree upon. Just because if there's just those big risks that they're taking afterwards if they're not able to do some of the things for themselves. So you also have central venous catheters and arterial lines. This can cause clotting, and it's mostly around the area where there's the insertion site. Typically, it's resolved once it's removed. And then you also have cancer, malignancy, and tumors. So if you recall, this was one of the things that we talked about being possibly um, a contributor to something being or becoming an embolus that can be sent throughout the body. Obesity, oral contraceptives, hormones, smoking. We also have clotting disorders. I like to tie in the contraceptives, hormones, smoking, and clotting disorders together. The reason that is because it affects how you clot. These can cause some inflammation, they can cause a lot of other things, but they affect the red blood cells where they're more prone to clumping together, causing those clots. In addition, we have heart failure. Heart failure as well. If the body's not perfusing correctly, you're not getting adequate tissue perfusion. Some of that blood is not being pumped properly, and therefore you're going to have a little bit more stasis as well. And that stasis obviously involves more risk for clotting. And then you have the fractured long bones, similar to the cancer, malignancy, and tumors, because you're having a source of an emboli. From fractured long bones, you have the fat emboli. So it should be noted that a really major thing that has been seen, especially in the time of COVID-19, is that because COVID causes so much inflammation throughout the body, there is a very high risk of clotting. And it looks like actually 20% of hospitalized patients with COVID-19 have had a PE. So clinical manifestations of pulmonary embolisms, they are varied and non-specific. And this is because of the emboli, where it's currently located at, the size and the extent of which it's affecting in the blood vessel. So you could have some dyspnea, tachypnea, which are going to be your most common symptoms once it kind of reaches somewhere in the lungs. However, this can clog up either a small vessel that affects an alveoli, or some alveolar sacs, but it can also be large enough where it takes over the entire pulmonary artery, as you saw in that first picture that we began. That's what we would specifically call more of a massive PE. So you could have pleuritic chest pain, hemoptysis, which is more of a severe symptom, cough, crackles, wheezing, fever, diaphoresis, tachycardia, and then you also have syncope or change in level of consciousness. So one of the main things that you're really going to want to do is to assess for signs of hypoxemia, and that would include a lot of those symptoms that we just discussed, but any type of cyanosis around the central cyanosis or anything like that, and then your typical signs for hypoxemia, O2 sats, and so after. So complications from pulmonary embolisms, besides death, which we discussed earlier, which can in the massive PEs is a big, big factor. And we also have some pulmonary infarction, so that can cause some lung tissue death. Now, where the tissue dies, it can actually cause some necrosis, and that necrosis makes it a site where bacteria can grow and cause an abscess. You also have the chance of causing some pleural effusion as well. And the pleural effusion, which could be any type of fluid, even from the hemorrhaging itself. Other complications can include pulmonary hypertension, which commonly occurs in recurrent pulmonary embolisms, not just one single event. With pulmonary hypertension, you would have patients who have hypoxemia associated with the massive recurrent emboli. Because there's this change in pressure within the pulmonary artery, it creates a big strain on the right side of the heart, which can cause the hypertrophy and lead to heart failure. And the issues with that, it can actually affect quality of life for a patient, resulting in quite a few other, comorbidity issues as well. But their quality of life and then also the length of life can vary too with that, depending on how severe it is. So diagnostic studies that we would do for someone who we suspect would have pulmonary embolism is a D-dimer. So a D-dimer is elevated with clot degradation. So fibrin is made, and when it starts breaking down, it creates a lot of these fragments, and that's what we're looking at, this clot degradation from the study. And the issue with that, though, is that it's really non-specific. So you could have some false negatives also with some small PEs. It just doesn't show enough. And then there are other disorders that can actually cause elevated D-dimer, such as arthritis, cancers, and things like that. The next thing we could do is a spiral helical CT scan or CTA. So this is most commonly used diagnostic test for PEs. It requires IV contrast media, which there you go, kind of is the issue with that. With IV contrast media, you can't use it for patients who have severe kidney issues, who are taking a medication such as like metformin. So it's something that we would have to move on to the next one for, which is the ventilation perfusion or VQ scan. So this is useful for patients who cannot have contrast media. However, it requires patient cooperation. So to be more successful, you have to have two components, and this is the perfusion scanning and then the ventilation scanning. If the patient cannot help with the ventilation scanning, such as if they're intubated or they are critically ill, then unfortunately you may not get the best results with these. So perfusion, it involves the IV injection of a radioisotope. A scanning device images the pulmonary circulation, and then with the ventilation, it involves inhalation of a radioactive gas such as xenon. The scanning reflects distribution of gas through the lung, and then therefore this is why you need that patient cooperation with this one. So while these may not be able to help diagnostically, these are other important studies that may be carried out in addition. So you have the ABGs, which can help demonstrate kind of how the respiratory system is functioning and how the body is reacting to it. You also have a chest X-ray, which can show any additional consolidation, the pleural effusion, or any other issues that might follow. You can also see from the electrocardiogram if there's any cardiac activity going on that may be abnormal, such as the AFib or CHF. You also can see the troponin levels and B-type natriuretic peptide, which also can clue in if there has been any heart injury involved. So interprofessional care. PE prevention begins with prevention of DVTs. So what this would look like is utilizing sequential compression devices, or SCDs. You may also use TED hoses as well, but you also want to have early ambulation for patients, and then also have prophylactic anticoagulation medications such as Lovenox. So the goals of care would be to provide adequate tissue perfusion and respiratory function, prevent further growth or extension of thrombi, and then prevent embolization from extremities to the pulmonary vascular system. And these can be done in a number of ways. So drug therapy that can be used for pulmonary embolisms include the anticoagulation regimen, such as low molecular weight heparin. This includes the Lovenox and then also Fundaparinex. So these are more recommended, and this is because they have a little bit more safety profile compared to the unfractionated IV heparin or even sub-Q heparin. What you would see for the heparin is that you have to monitor the BTT levels a little bit more closely, and you have to also reach a therapeutic level with these. So there's going to be some frequent monitoring. Now, with our oral medications such as warfarin, apixaban, and dabigatran, warfarin will need some constant monitoring to ensure there's a safe therapeutic level for this. However, with the apixaban and dabigatran, you have a little bit more freedom, and so patients should be aware of that. With the fibrinolytic agents, you have the TPA, the alteplase. However, these are less commonly used within the hospitals, but they have the potential to be. So if a patient, unfortunately, just isn't a candidate for some of these medications, potentially because they're just hemodynamically unstable, there is a potential for surgical therapy such as pulmonary embolectomy, which they just go into it and take out the embolus directly. And then you also have inferior vena cava filter. So you have this picture right here that shows this device which they will place into the pulmonary system or the arteries. And then actually what this will do is it'll prevent the blood clot from flowing into the pulmonary system. So nursing management, you want to think about your ABCs, and this includes your airway, breathing, and circulation. So with the patient in respiratory distress, you want to put them in the semi-Fowler's position. You want to administer oxygen, assess their cardiopulmonary status, and then you want to do frequent follow-up monitoring, especially to see if any of the interventions are working. You want to ensure that there's good IV access, and this can relate to whatever medications you need to give or any associated issues going on, such as sepsis or the AFib. You also want to monitor laboratory results because these are good indicators of what's going on as well and to see if your interventions are working. And for the patient, you want to ensure that you have good emotional and physical support. So for the patient, this can be a scary event, especially if they have those feelings of impending doom that may come from respiratory or cardiac issues. And then also with the physical support, they could be in pain, the pleuritic chest pain, so ensuring that you're accommodating each thing. You want to also provide education and reassurance. So the education, what this means is that you're going to provide information on preventative measures, especially for patients who just got out of surgery. You want to avoid sitting, crossing legs, pillows beneath the popliteal fossae, and then wearing tight-fitting clothes. So the pillows beneath the popliteal fossae, that is a big one. You don't want to have pillows underneath the knees. That is a big ortho no-no. And then also wearing tight-fitting clothing. This is basically items such as girdles. You want to ambulate the patient as soon as possible. You want to inform them about the anticoagulant therapy, which we kind of discussed, and also reinforce the importance of follow-up exams, especially if there's any bruising or anything like that, or any associated issues. So these are the references that I have for you, and I want to thank you for listening to this presentation. If you have any questions, please let me know.